All right, we are back. Chapter 9, Part 2. We're starting to move into gastrointestinal dysfunction. Tons of things can go wrong, and we're going to give you a whole bunch of them. So there are some changes affiliated with aging. Gastritis can happen, decrease in hydrochloric acid, B12 deficiency, decreased digestion. You know, things just get worn out as we get older. The liver starts to get some scar tissue, so it doesn't have as much blood flow, and the whole gist with the liver is blood flowing through it in order to process the blood, clean the blood, and put nutrients into the blood. Changes in lactose, we can't absorb lactose as well as we used to. Calcium, iron, etc. And decreased peristalsis, I think, ties in with decreased digestion. Things just wear out. So different conditions, this lists different conditions that we will be talking about, and it has them listed under upper GI, liver, and pancreas. We'll talk about some lower GI issues as well, and some cancers. So they have them all listed. If you would like to read through them, I would prefer to just get right into it and explain them one by one. So cleft lip and palate. If you remember, the front of the palate is the hard palate. If you take your tongue and simply push up, it's hard. That is where your teeth attach into the maxilla. That's the maxillary bone. If you look in at your uvula, that's part of your soft palate. So we have a hard palate and a soft palate. Cleft palate is when there is non-union either of the front of the hard palate, the front, middle, back of the hard palate, and can go all the way back through that soft palate. And the problem with this, obviously, is appearance issues, because it's pretty obvious. But with an infant, they can't suckle. They can't create the suction that they need in order to suckle from the breast or a bottle. So feeding's an issue. They are able to surgically fix this pretty well. Thank goodness. Pyloric stenosis, if you can pause and just think for a minute about the narrowing of the pylorus, where at the bottom of the stomach it meets into the sphincter. In some infants, at approximately 3 weeks of life, you can get an over-narrowing of that pyloric sphincter and the pylorus of the stomach. And the difficulty with this is they can't get milk or formula through that pyloric sphincter into the duodenum, and if it can't get there, they can't absorb it. So manifestations of this would be hard mass in the stomach, regurgitation, and like projectile vomiting. I mean, they're really projecting. Failure to gain weight is another thing. My kids puked so much when they were young, but they were the fattest little babies, and I just could never get over how much they could eat and eat and eat and puke and puke and puke and still put on weight. But that's the key, is putting on weight. And dehydration, you need to check for as well. Always making sure that anterior fontanelle is not sunken. So dysphagia is just difficulty swallowing. It could be that there is some sort of scar tissue or narrowing in the esophagus. It could be a tumor. Stroke can damage the cranial nerves that go to the throat, primarily 9 and 10. I didn't put those in because I didn't want to kill you guys too much. Cerebral damage would lead to the loss of the ability of those nerves to work as well. So this would manifest, obviously, as the sensation of food being stuck in the throat. And here's a picture of it. I know this is pretty self-explanatory, and they have a whole list on the left. You don't need to know that. You need to know, once again, what's in the notes. But the reason that I put this in here is you can see how a tumor could push in on the esophagus, and it also shows how scar tissue can cause a constriction of the esophagus, not allowing it to pass. Finally, this is where the diaphragm is. So this would be where the esophagus meets the stomach. If a hiatal hernia goes really high, it can create this expanded area above the diaphragm in which food can collect as well. Let's practice. So this might be a little hard to tell. Believe it or not, this was a hard one to get a picture of. What do you think this might be? It's actually not that difficult. Okay, dysphagia. And obviously that little bolus is going down the trachea, so that would be a problem. This picture is interesting, slightly confusing, but I'm trying to make you think a little bit. Out of what we've gone over so far, this would be your cleft palate. The interesting thing is this doesn't show through the anterior part of the maxilla. It's in the posterior. So you can have those congenital defects further back. What do you think this might be? Get oriented first as to the anatomy. Thickened muscle in that region would be pyloric stenosis. Oh, the answer is up here. Pyloric stenosis. And you can see how the food can't get past that into the duodenum, so the child can't absorb nutrients. There's some absorption in the stomach, but not of major foods. I think the majority of what is absorbed in the stomach is alcohol and aspirin, some proteins, and kids aren't taking aspirin and they aren't drinking alcohol. So obviously they will be malnourished if they can't get food into the intestines. This is a more stereotypical presentation of a cleft lip and palate. And usually it'll start more in the front and move back. Vomiting is our next topic. Yay. Okay, and I buzz through this because I hate talking about vomit. This is involuntary or voluntary forceful ejection of chyme from the stomach, and it actually can come all the way from the small intestines. I saw a PET scan of it once. It was disgusting. It's coordinated by the medulla, and this is something that I do want to benchmark or earmark on the notes. The medulla actually has in the brain, there's something known as the blood-brain barrier where we keep certain substances out. There is a small area of the medulla that is lacking that blood-brain barrier. And it does so because it's constantly testing the blood for infectious or dangerous agents. And if it senses something such as food poisoning that is dangerous for us, it can initiate that vomiting reflex quicker. So aspiration is an issue if someone is vomiting and they are lying supine. This is obviously, everyone knows this, why you put people on their side. Hematemesis is blood in the vomit, and this has a coffee grounds appearance from protein in the blood being partially digested. This is obviously not a good sign, right? So blood would be irritating that gastric mucosa, or they could have something that's bleeding in the GI tract. And this would be upper GI. If it were lower and blood were in it, it would create that either occult blood, if it's not a lot, or the darkening of the feces. Hiatal hernia, we've spoken about this, and this is when the stomach section protrudes up through the diaphragm, and it can begin with a cardia, and it can move even high enough to bring part of that fundus or the rounded portion of the stomach up. Causes for this would be a weakening of that diaphragm. There could be an increased thoracic pressure or abdominal pressure, which simply pushes the stomach up. Obesity does contribute to this as well. Not all the time, though. Not all the time. I've known very thin people that have hiatal hernias. They would have manifestations of abdominal symptoms that would be pretty obvious. Indigestion, heartburn, belching, nausea, chest pain. Some people feel like this gives them almost like an MI sort of pain. Worsens after laying down, eating, bending over, coughing. All your typical presentations. Now, gastroesophageal reflux disease is when chyme from the stomach backs up to the esophagus. So this can go hand in hand with the hiatal hernia as well. It can be a separate thing where you have a little weakening of that sphincter between the esophagus and the stomach, and chyme can get back up. Okay. Gastric secretions, it says bile as well. Just think of it as gastric secretions stinking back up. And the problem with that is it can damage the esophageal mucosa or the inner lining. And the cells in the esophagus can actually change and thin and become one cell layer thick. This leads to your Barrett's esophagus, which can lead to precancerous states. So this could be from food, from alcohol, from nicotine. It can be from hiatal hernia, obesity, a weakening of that sphincter. Any of those can contribute. Patients get heartburn, epigastric pain, which is sort of like right below your xiphoid. They can get difficulty with swallowing, pain with swallowing, dry cough. Some physicians will actually screen for GERD when you have a dry cough because the acidity comes up and will actually get a little bit into the larynx and the trachea, causing a reflexive dry cough. Laryngitis can happen because you could get the acidity into the larynx, regurgitation of food, swelling of the pharynx as well, sensation of a lump in the throat. Often confused with angina and may warrant ruling out cardiac disease. Always want to rule that out, right? Gastritis would be inflammation of the stomach's mucosa. This can happen with stress. People can have increased acidity in their stomach, but one of the main causes that I would like to talk about is H. pylori or Helicobacter pylori. This is going to be the most common cause, and it's this funky corkscrew-shaped bacteria that digs its way into the stomach lining, and it can lead to ulcerations and or inflammation of the stomach's lining. And the reason it's important to know about H. pylori is because it's treated with antibiotics. So if somebody has it, and I'm not talking much about treatments, but if somebody has it, they could get treatment and do pretty well. So complications of chronic gastritis could be peptic ulcers. We'll talk about the two types of peptic ulcers in a little bit. Gastric cancer and bleeding or hemorrhage. So your typical presentations of indigestion, epigastric pain, cramping, nausea, etc. And also you can be vomiting blood as well. Dark tarry stools is another indication of possible bleeding. Usually that's lower, but that can be actually as high as the duodenum, leading to dark tarry stools. So H. pylori you could test with antibodies, a breath test, stool analysis. From what I understand from my GI doctor, the best way to test is to actually go in there and take a sample. So let's talk about peptic ulcer disease, and these are ulcers that will affect the stomach or the duodenum. This can happen from H. pylori, which we just spoke about, but also from NSAIDs. So your Advil, for example, or Aleve can actually cause, as one of its side effects, a decrease in the protection of the stomach and the GI lining. I have heard in the past that they can actually embed in the wall. That's not the issue. The issue is that they decrease the ability of the stomach and the duodenum especially to create a protective lining for the surfaces on the inside of them. So these could be just superficial erosions to a complete penetration through the GI tract wall, and that complete penetration could lead to bleeding that can lead to dark tarry stools. So we have duodenal, which will be in the duodenum, and gastric, which will be in the stomach. So the difference between them is duodenal will present with epigastric pain that's relieved in the presence of food. Gastric will usually worsen with eating. Is that always true? Not always. Okay, so there can be a little bit of overlap with these presentations. So H. pylori can lead to duodenal as well as gastric ulcers. I think there's crossover with that, but your book has H. pylori more with duodenal, and gastric usually would be from NSAIDs. I'll ask you these as a whole. I won't ask you to differentiate between them because I think there's a little bit of crossover. So complications, GI hemorrhage leading to peritonitis, and then all those presentations of gastric pain that we spoke about previously, which I think there's a lot of crossover with that as well. So once again, if there's crossover with symptoms, guys, I will not confuse you with it. I'll be very clear in my questions about what belongs with what. And if there's crossover, I'll ask more generalized questions. Cholelithiasis is gallstones, and these are calculi which we've spoken about in the past. Cholecystitis is going to be an inflammation or infection in that biliary system, and the biliary system are the tubes that we spoke about. And those tubes lead from the liver, gallbladder, down to the duodenum. They can get obstructed, and if they become obstructed, they can cause inflammation. Then inflammation can go into the biliary system, all the way back to the liver and the pancreas. People who have gallstones, I passed, I think, a gallstone once, or I had an infection in there, I had pain. Oh my goodness, I thought I was dying. I literally called my husband from work and said, you need to come home. Like, I'm going to the hospital. And then it just passed. So I don't know if I had a small one that passed, but it was right where gallstone pain is, in the right shoulder. And it was remarkable, to say the least. So, pain. Pain in the right shoulder blade, abdominal distension, nausea, vomiting, jaundice if you're getting any type of hepatitis, fever as a sign of inflammation, and increased white blood cells. So, here's that biliary system again. I thought this was a good picture. Once again, you need to know hepatic duct from the liver, cystic duct from the gallbladder, and they join at the common bile duct, or you could just say bile duct. You can also see how the pancreas dumps into the duodenum there, and that's just the pancreatic duct. That's all you need to know. Okay, there is more. That's all you need to know. So let's practice a couple things here. So some stomach disorders. What do you think is this? And once again, really think about it. Normal is on the left. What's the anatomy there? Abnormal is on the right. What's the anatomy there? And that's what's happening. And I think this is a really good representation of that hiatal hernia. And you can see how the stomach comes up above the diaphragm, and the esophagus gets pushed up as well. This is a little tough, but take a guess out of what we've just recently spoke about, what could create that hole-like presentation. This is an example of a peptic ulcer. Okay, that's pretty indented there. So this could be gastric, this could be duodenal. They'll present as the same. Once again, I wouldn't ask you to differentiate between them. I'll ask you to know where they are. Duodenal is in duodenum and gastric is in stomach. But I would never give you this picture and say, which is this? Duodenal or gastric? I think guess is on this one. This one's a little bit more difficult. Out of what we have spoken about, what do you think this might represent? This is going to be GERD. And you can see the acidity coming up, and it's just changing the lining of the esophagus into a different type of cell. Let's take a peek at this one. And once again, you can always pause the tape if you need more time. But yeah, this is easy, right? This is an x-ray of cholelithiasis, or there's those stones in the gallbladder. And the calcium makes them more able to be shown on x-ray, just as the calcium in your bones does. What do you think this one might be? Yeah, I thought this was good because when it comes to these peptic ulcers, I will ask you to differentiate them by location, not by symptoms or etiology, which means cause, by location. So there's duodenal, And duodenal likes to be in that first little roundabout corner there. And stomach, ulcer would be obviously in the stomach. I'm going to pause the tape there looking ahead. We're getting into hepatitis and cirrhosis. I would like to continue with that in one long video. So take a little break, get yourself a cup of coffee, and I'll see you in the next video.